Good afternoon, everyone. So let me introduce you my PhD topic regarding point-of-care devices in the management of illnesses leading to shock. So I'm Gabriella Rapszky. I'm working at the emergency department as a resident, and my supervisor is Bank Fenyves. And my vision is to improve the management of patients presenting in the ED and by contributing to the development of the guidelines. I have two ongoing projects right now. In the first one, we are conducting a meta-analysis regarding rapid molecular assays. And in the second one, it's also a point-of-care device, a viscoelectric method guided therapy is obtained. So in my first project, we are investigating these rapid molecular assays in the diagnosis of bloodstream infections. Because sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection, and it's affecting a lot of patients worldwide. And early management of this condition has been shown to be associated with improved outcomes. The problem with the gold standard diagnostic method, the blood culture, is that it has a long turnaround time, so it takes around 2 to 3 days to get back the results on average. To resolve this problem, rapid molecular assays are already existing on the market, which allow earlier pathogen detection and identification. And these tests could be performed on several samples. In our review, we included the ones which are performed on whole blood, because without the culturing step, even less turnaround time can be achieved. So our clinical question we used in our meta-analysis is what is the diagnostic accuracy of these rapid molecular assays in the for bloodstream infection. We included patients of all age, and for the index that we pulled the diagnostic measurements of the rapid molecular assays. We used the gold standard as the reference test, so the blood culture, and the diagnosis was bacteremia, and we hypothesized whether that the diagnostic accuracy is non-inferior to the gold standard. So our clinical implication was to provide faster diagnosis in patients with bloodstream infection. You can see the search key below. We conducted in January in 4 databases, and it resulted in a high number of articles. At the end, based on the full text, almost 100 articles could be eligible, but only data extraction was possible only from 75 articles. So we have some preliminary research results. Regarding the data provided in the articles, there were articles which in the authors provided sample numbers, and there were articles where they provided patient numbers. And there were also studies in which both data were mentioned. You can see the analysis couldn't be done all together, so the articles with the patient numbers and sample numbers, the analysis had to be done separately. We also made a subgroup analysis on the population we found in the articles. For example, here's the population of emergency department articles with 10 articles in the patient number group and 7 in the sample number group. As you can see on the rock plot, the sensitivities and specificities is not quite different in the groups, and also it's not that high as we expected. So it's around, as you can see in the table, it's around 0.60. It's a little bit above. And here's an example. I brought these figures of the emergency department population that it's not different from the pool results. So it's not lower or higher the diagnostic measures. And it was the same result with all other populations as well. During our search in the literature, we found several devices available or yet already off the market. The Semmelweis device had the most articles with the 51 included, and you can see all the devices in a decreasing order of the articles we found. So based on the subgroup analysis of each device, we found some differences. For example, at the top, there is Iridica, the blue square, which performed better than the other ones. But based on that, we can't yet draw strong conclusions because we need 4 more articles to include in the analysis, so we are currently working on that. So this is my progress in the first project. We finalized the data extraction, and now for September the plan is to use the risk of bias assessment and also the grade. In my second project, we are observing other point-of-care device, ClotPro, which is a risk-selected method, and we try to investigate the association between the use of ClotPro with blood products used in mortality in patients with gastrointestinal bleeding. Gastrointestinal bleeding's incidence is 32 to 47 per 100,000 population. In patients, risk-selective methods such as this ClotPro we have at the department provide a rapid assessment of coagulation and facilitate a more accurate targeting of therapy compared to the conventional laboratory tests alone. The guidelines are already recommending the usage of this ClotPro in trauma patients and with perioperative bleeding patients, but there is no strong evidence of the benefit of the usage of this risk-selected method in massive gastrointestinal bleeding patients. But the benefit might be extrapolated in the future. So our aim in this study is to observe the differences in the management when ClotPro is used. So our clinical question, does the use of ClotPro influence the management of GI bleeding patients in the ER? And we will include patients with GI bleeding, and the comparator group and the intervention group would be patients where ClotPro is used and when it's not used. For the outcomes, we would use for the first a composite outcome, and for O2, a total blood products used. And we have 2 hypotheses for this project. The first one is whether ClotPro improves the clinical outcome, and the second one whether it optimizes the number of blood products, because blood product usage has a side effect. So disadvantages. For this project, we have an own database at the emergency department, so we would work from that one. So our clinical implication is to optimize the allocation of these blood products. So I have these 2 ongoing projects right now. We are working on the first project, so there's no progress with the second one yet. But we hope to soon finish the first one, and also the manuscript we will start. And thank you for your attention.
Thank you for your presentation. My question is that, according to you, using ClotPro in the emergency care will reduce or elevate the using of blood products? Because it can happen that they realize in time that the clotting parameters are bad, so they need the blood, or it can cause that they realize that they don't need it. So what do you think, which is the more frequent option?
Well, as I experience it, we rather do transfusions at the ED, and with this project we try to find the correct point where it's worth giving blood products, and so our point with this retrospective study, whether we can have conclusions on if there is a point where it's worth not giving blood products at the limit of the parameters and the lab results. So we're trying to find that point, actually.
Okay, thank you.
Thank you for your question.
Congratulations. I just would like to ask, what will be the conclusion of your first project? What would you recommend in general practice? Thank you.
Well, thank you for your question. That's a really interesting question, actually. We need more 4 articles to include in the analysis, but based on the current results, we would need more studies to investigate the devices on the market, because some of them are already off because of the low sensitivities. So actually with our study we may draw attention to the lack of studies regarding new devices on the market.
And what is your practice in your department? Do you use any of these devices that you mentioned in your first project?
Thank you for your question. In the first project, we don't have those at the ED. We have a different one in the central lab, which uses the whole blood, culture samples, but not whole blood samples. We don't have it.
And what else do you use? What else do you measure if you think that the patient has infection?
Well, we use the lab parameters, and also we do a blood culture. So if we are suspecting sepsis.
But what lab parameters are interested
like,
in this?
like CRP and PCT is important as well, and also the kinetics. So
you measure PCT regularly?
Yes, most of the time when we are yes. Thank you for your question.
Congratulations. You should also be in our group, right? So, well, regarding the first project, on your summary slide, you said that the data extraction, you don't have to go back, the data extraction is finished, but then you are talking about 4 more articles.
Yes.
What's that?
Yes, the data extraction is finished, but the 4 more articles is, we used recently the citation chaser program, and that one we find 4 additional one which can be added to the ones we found with the search keys. So we already extracted those, but we haven't talked with the statisticians yet. So that's the 4 articles I mentioned.
And regarding your second topic, what is the mortality rate of patients in acute GI bleeding? Because we didn't get that on your background slide.
Yes, only the incidence, but I have to look it up for.
I tell you why I'm asking. If you should really check it, because you are doing a retrospective study, right? And in one center.
Yes, that's
okay?
right.
So you will have very few patients. And you will divide those patients into ClotPro versus no ClotPro assisted bleeding management.
Yes.
So if the mortality is anything lower than 10%, it doesn't make any sense to use 30-day mortality in your composite primary outcome. You can use it as an exploratory outcome or a secondary outcome. Even I would rather just stick to the exploratory. So however intriguing and sexy mortality looks like, it should not be really your primary outcome. So I would really rethink it, okay?
All right, thank you for your...
You need a large sample size to come to any conclusion regarding mortality. So I would rather use blood products, the use of, that was a very good question, because you will use more blood component-based management and not just giving plasma and blood and platelets kind of thing. Yeah,
but
okay.
Thank you and we will discuss it with the group. Thank you.
One last question.
Just a quick question. So the second project is a retrospective study, not an RCT.
No, it's not
so
an RCT.
do you know of any confounders, like big variables that you think may lead to a preferable choice? Like, let's say there are 2 doctors who love to use ClotPro, 10 others hate it, and the 2 are really good, or anything like this?
Yes, that's really well. Thank you for your question. There will be confounding factors, as you mentioned, that some of the seniors or doctors like to. The trigger point of transfusion may be different for some doctors, but we have kind of the same opinion about that, and also we have a booklet of the blood products all used, so maybe we can work from that. But that's a really good question, but these circumstances is under discussion yet, so thank you for your...